My name is Mohammed Hashim. I'm working at Heather with the Wixom, Northwest London. So I'll be speaking today about Vancouver B periprosthetic fraction and our experience and our reduction in tendon fixation. So I have nothing to disclose, and I have to acknowledge my team. So basically, we're shedding some lights on the dilemma of Vancouver B2 periprosthetic fracture between fixation and revision. So the problem comes from the NGR, as we see, about 105,000 primary total hips every year. This is elected to increase to 130,000 cases in 2060. The median age is increasing from 69 at 2017 to 73 in 2022. And it's a lot of research and a lot of literature speaking about the Vancouver B2 fracture and what can we do before the revision. It definitely have a financial impact on treating the femoral periprosthetic fracture. So as a revision surgery is a complex surgery, it costs a lot. So it was costing about 23,000 pounds in this 2011, which is definitely much more now. So the current debate, shall we revise every case of periprosthetic fracture Vancouver B2, or we still have an option before revision? A lot of systematic reviews which has shown that revising open reduction in tendon fixation is still an option to do before revision of these cases. So most of the literature agreed that open reduction in tendon fixation have been associated with satisfactory outcomes with certain and ongoing discussions to show that this outcomes is comparable to the revision. So we can save more time, more surgical time, and more financial impact to the patient. So the problem was, we asked our question, is open fracture in tendon fixation is a safe and effective option to manage Vancouver B2 periprosthetic fracture in frail elder patient? And we were searching for our primary outcome is the revision, and our secondary outcome was the length of hospital stay, time to mobilization, and definitely the PROMs, including the Oxford Hip Score. So between May 2022 and November 23, we received 15 patients with Vancouver B2 periprosthetic hip fracture. As we can see, all are elderly, so the mean age was about 84. Most of them were women, and all of them were frail, all of them were medically unfit. They are AC3, AC4, nearly about 70% of them. All of them have a very low impact trauma with domestic falls. They have a reasonable mobility before the fall, and all of them were Vancouver B2 periprosthetic fracture with variable degrees of stem loosening and subsidence. We operate on them within 1 to 3 days post-trauma. Only one case was delayed because of a delayed diagnosis. We use for all of them the VA synthesis plate, and we do them under spinal anesthesia, image intensifier. We do them in a lateral position with side supports, and we use antibiotic and tranexamic acid on induction for all of them. Our technique is nearly standard, so we do a vasa-splitting lateral approach to the femur. We do provisional reduction, and we stabilize our reduction with cables. Then we do bottom plate with proper size, which we're sizing before the operation. We haven't used any lock plate, and we do as much as we can absolute stability proximal around the stem, give a very good working length to the plate, and just a distal fixation with 3 screws. Then we reinforce this fixation with 2 to 3 cables through the eyelets of the plate itself. We do we maintain a good working length of the plate in all the cases. So post-operative protocol is nearly standard again, so we put them to full weight bear day 0 with no precautions. We have an excellent also geriatric and physiotherapy input. We discharge them when they are safe and mobile, and they see the GB in 2 weeks to remove the suture and check the wound. And we see them in the clinic at 6 weeks and at 12 weeks for a radiological and clinical follow-up. And we discharge them from the clinic once there is an evidence of union and the patient is mobile. So our results from this study, we have a main follow-up duration of about 10 months. 2 patients unfortunately passed away during the follow-up, one at 10 months and another one at 14 months. Our main surgical time was about 2 hours, and 60% of the patients were done under spinal anesthesia with or without additional sedation. Remaining patients were under general anesthesia. We have only one intraoperative complication, which was a persistent bleeding from a patient on warfarin. This ends by acute blood loss of about 1.6 liters. There was no recorded inpatient mortalities, and our average time to mobilization was about 4 days. All the 15 patients were successfully discharged back to the community in different times according because we have a bit of difficult discharge. So there was no revision surgery. So our primary outcome, there was no revision surgery during the follow-up period. Our main length of stay was about 24 days, as this is mainly because of the discharge issues and medical issues and not related to the operation or the orthopedic problems. Before discharge, we have 4 patients who developed delirium post-operatively. They are elder and frail. 2 patients developed hospital-acquired pneumonia. 4 patients had wound problems, and all the wound problems was just oozing or superficial infection, and some of them has contributed to delay in discharge. 5 patients has delayed discharge, as I told, because of the package of care and discharge planning. Oxford HIP score was collected for 13 patients who remain alive at the end of the study period. The main Oxford HIP score at most recent follow-up was about 30.5. 23 of the patients had no pain at all at the hip. 15% of them had severe pain, and 85% of them didn't experience any pain without mobilization in bed. 54% of these patients reported they will be able to do a minimum of 30 minutes walk before they develop severe hip pain. So, as the figures show, most of them had about mild to moderate pain on the hip, which is expected in such an age and a major surgery. There are very minimal who had a severe hip pain, which is limiting the mobility. And to show some cases, so my first case is an 89-year-old lady who had a background of hypertension, AF on apex span. She lives alone, mobilized independent indoors with a stick outdoors before the operation. Her mode of trauma was fall at home, which again is low impact trauma. Has an uneventful intraoperative period, and post-operatively was uneventful as well. So as we see, she has a cemented total hip. In the X-ray, it's a very clear fracture around the tip of the stem, and there is a clear fracture of the cement mantle. So we do the same technique. This is the intraoperative pictures. We did a proper and very rigid fixation proximally, good working length, just minimal fixation distally, after a good achieved reduction and fixation. This is her second day post-op X-ray, and in 3 weeks' time, everything was maintained as it is. So 12 weeks post-op, this is the signs of radiological union, and clinically she's at 12 weeks, she's walking with just 1 stick, and she's back to her normal mobility before the operation. Just for the sake of the time, so the second case, 80 years old, who hasn't fallen on the ground. She's well and fit, had her hip replaced 5 years ago. I showed this case especially because she has an accolade hip replacement, which is uncemented, which most of the literature is away from uncemented stems. And the fracture is in the medial calcar, which is most of the people will revise such a case. Again, the same standards protocol, operative protocol, we achieved the reduction even with some subsidence of the stem. This is the 12 weeks post-op, there's an evidence of union, and the patient is mobilizing well. So, in our study, all 15 patients went a successful OP reduction and tendon fixation. There was no revision procedures. Post-operative Oxford HIP score, mobility status, and pain levels were acceptable. Most of our cohort had a mild to or no pain at mobility. The elder patients who undergo OP reduction and tendon fixation, but they still maintain a good quality of life following the surgery. So revision to a long stem arthroplasty requires a more substantial procedure with greater soft tissue. OP reduction and tendon fixation may be a favorable option in elder patient, and this is particularly with the patient with high risk of anesthesia, which tend to be more prevalent in this age group. So my message is fixation to a fracture with a stable construct is, even with cement mantle fracture, is still a valid option with low cost, low blood loss, low surgical risk, and operative time with early rehabilitation. The VA plate is a very good option with good principles of fixation. Definitely we have a limitation of our study, which is the sample size, the shorter follow-up, and it's retrospective, and I think more studies are needed. Thank you so much for hearing.
Thank you, Dr. Mohammed.